All right, good morning, folks. We know we have a fairly large number of registrants, but we're already past the top of the hour, and we are mindful of your time. Thank you for joining us this morning and for joining David Szabo, healthcare practice leader or co-practice leader from Locke. Um, just a couple of notes. We have uh, Twitter hashtags for those who are interested in tweeting, if you do. And we follow the usual rules of order, which is feel free to speak at any time and ask questions of David as we go through the presentation. Many of you know David Szabo very well. All of you know David, and I think he requires no real introduction other than to say that he has been a member, a board member, a board chair, and continues to be on the board of the Health Data Consortium. And we hope to continue working with David for as long as we can do so. If you have questions, feel free to unmute your line or type a question into the chat box. This is a free-flowing conversation, and we want to be sure that people have a chance to ask questions while we're talking and while the presentation is underway. So I'll ask our chairs, Bill Young and David Carusio, if you have any words you want to share prior to the start of our presentation.
David, do you want to go first? And he may be on mute, so maybe I'll jump in. David Szabo, thank you. You know, you have been such a leader, supporter of what we do at MHDC, and this time this morning with your valuable insights. Just want to say thank you, and I look forward to it.
Well, you are quite welcome. It's always a pleasure to do stuff with the Data Consortium. And I'll just permit myself one reminiscence. When I think about all the things we've seen really since 2009 with meaningful use dollars and ONC's work, and lately a whole raft of new rules around interoperability and patient data and sharing of information. I always say to myself, I wish Elliot Stone could have seen all this stuff, because I think in his mind he imagined it many years ago before we had the technology to make it come true. And it's just been fascinating to see how things have evolved and unfolded over the years. But thank you very much. With that, why don't I just get into it, Denny, unless there's a reason not to. So let me say a word about
by all means, David.
Oh, go ahead.
No, please go ahead.
The title of this is slightly tongue-in-cheek, the regulatory sprint to coordinated care, and I'll explain that in a moment. Why don't we go to the next slide? There we go. So the regulatory sprint to coordinated care is something I've heard a lot at legal conferences, talking about a variety of rules, really starting with the government starting to respond to industries' repeated and louder requests to liberalize the anti-kickback safe harbors and the Stark regulations to allow providers and plans to set up arrangements to promote value-based care, and a feeling that these very important rules and rules with enormous negative consequences if you violate them were really impeding a lot of the plans that folks had for value-based care, whether through ACOs or other kinds of contractual arrangements, to give hospital systems, integrated delivery systems, and physician groups incentives to promote new modes of care and new organization. So the government announced in 2008 that they were going to have a regulatory sprint to allow coordinated care. The new rules came out, I think, on Stark and anti-kickback. I believe it was toward the end of 2018. That makes it a 10-year sprint. You probably all have learned one time or another about the messenger who ran and ran to report the victory at the Battle of Marathon, only to drop dead just after he had announced the news. That's what I feel about the regulatory sprint. Somebody's been running for over 10 years. They're probably all done at this point. It is kind of remarkable. So, but you know, this is dealing with the federal government, and for them coming up with announcing an idea in 2008 and continuing the work in 2021 is a sprint. So we just have to, that's my tongue-in-cheek critique of some of the stuff that's been going on for a while. So we have seen the amendments to Stark and anti-kickback really are only coming into play now, and I'm not sure how much difference they're going to make, frankly. We've seen ONC rules on interoperability, the ONC rules on information blocking, the CMS rule on health plan data sharing, and also ADTs for providers. The HHS rule on price transparency, very, very controversial. And by the way, I saw something in Modern Healthcare yesterday that said 60% of large healthcare systems have yet to implement anything around the HHS price transparency rule. I think my expectation is large segments of the industry will continue to drag their heels until someone is plunged in. And I see the comment about except when they announce a rule and finalize it in a month. Well, we get both extremes with the government, right? Some things they say, here you go. And if I understand that comment correctly, that probably relates to rules that come out at the end of an administration, where, you know, there's the old saying, take out the trash day. In this case, it's not when all the bad news is dumped out on a Friday afternoon. In this case, it's all the rules you didn't have time to work on, but you want to get them out there as either final or proposed, because maybe the folks in the new administration would have been thinking about other stuff and are going to do other stuff. And I think that's what we're seeing now with some of these rules. Now we have two more installments in the regulatory sprint, the proposed HIPAA amendments and I should have said proposed Medicaid burden reduction. I think also calling this the second rule burden reduction is also kind of an ironic twist, but you know, it's kind of a variation on newspeak. You know, when I say Ministry of Love, what I mean is Department of Defense, and on and on. Why don't we go to the next slide? So the HIPAA privacy rule proposals, and before I get into this, I just wanted to say, I tried to root around a little bit and find out where these things sit in the sense of, is OCR going to carry these through? And while I don't have a definitive answer for you, I will say that some of these themes in this rule do build on things that OCR has been banging the drum on for a long time. So they're not exactly, in terms of what they're trying to accomplish, you know, it's not exactly, holy cow, where did they come up with that idea? Some of them, I think, are straightforward responses to things that people have been concerned about in industry. Some of them are just extensions of things they've been trying to do, and one of them is a result of a response to a lawsuit. So the points that I'll highlight from this rule is they're taking steps to expand and strengthen the right of individual access to their protected health information, including the right to direct the information to go from one place to another. And that's been a bit of a controversy, especially when it comes to copying costs. They make some clarifications around care coordination and case management, which I think Denny is probably squarely on with some of our initiatives and the things that folks have been talking about here in Massachusetts, exempting care coordination and case management from the minimum necessary use rule, disclosure to social service agencies, which I think in particular is probably a big deal for things like our Medicaid ACOs and other Medicaid ACOs around the country, where you have populations that need additional long-term care and supports, whether that's through Part 2 programs or nursing homes or home health agencies, not so much home health agencies and nursing homes, but social services agencies, maybe people that take care of the homeless, people that provide food support. folks that provide supportive housing and getting them more in the loop of data sharing, especially, again, I think for patients with disabilities and chronic illness. A liberalization of the rule for certain kinds of emergency disclosures, which I'll get into, and especially disclosures to avoid harm. Eliminating something that was ridiculous when it was first implemented, back when Bill Clinton was running out of the White House, which was the acknowledgement of the notice of privacy practices and asking the individual to sign something that says, yes, you offered me the NPP, whether I was interested in it or not. It was a problem when it was first proposed. It's been a problem since basically 1999, year 2000. So 21 years later, we get to get rid of it. Thank you very much. Additional required disclosures on the NPP regarding certain patient rights. This is one where I think people are really going to bark about administrative costs, having to create a new NPP, circulate it, put it at either the point of care for plans to send out a new one. So we'll see if that survives. And then some liberalization, really a clarification about the use of telecommunications relay services. I have a question, which does that mean that patients don't have the right to see the privacy rules? No. Covered entities are still supposed to provide the NPP at the point of service if they haven't given one to the patient before. Plans are still supposed to send out their NPP, but providers often got tangled up in their PJs when they said, oh, we'd like you to sign this acknowledgement of the NPP. And the patient might say, well, I don't agree with everything that's in here and I won't sign. Or does this mean I'm giving up my rights by signing this? It was really something that just was very difficult to explain at the point of care, and I think served very little purpose. I will say that CVS and Atrius have stopped trying to give me my NPP for a long time. Every time I filled a script, I got the CVS NPP. I don't know if that means they just can tell in their system I've already seen it before, or whether they've just given up printing all that paper and handing it out.
Hey, David.
Yeah.
Yeah. And is that required every time you go to the physician or see your doctor now? Because I think
it's really only required when you have an encounter and you haven't received the most recent version of the NPP before.
Got it.
So if you've got the current version they're using, if you got it 5 years ago, they don't have to give it to you again. They're all supposed to post it. I think kind of some of the thrill of doing that activity is worn off a little bit, and people are getting a little slack about it in any event.
Yeah.
Why don't we go to the next slide? There we go. So the right of access. Here are a few things that they've proposed in this rule around the right of access. And I'll say this has been a hobby horse for OCR now. Really, I think since the end of the Obama administration, even during the Obama administration, they were saying, while we're still very concerned about privacy and we're very concerned about security, we feel the industry has really been lagging on the right of access, and we continue, and they say this through today, we at OCR continue to get a lot of complaints about finding it difficult to access our records. And people saying we're not getting them when we want them, people put barriers in our way and that sort of thing. So, the government in its own way is trying to be responsive to those complaints. They have stated as follows, that the right of access includes the right to take notes, videos, or photographs of the medical record, not videos of what's going on in the medical office, but if someone comes in and looks at their record and they want to take a picture of it with their device, you can't say to them, "Oh, you're not allowed to do that." That would become a right to some, or to just simply to take notes. I'm kind of surprised that there are providers that objected to patients looking at their record in real time and making notes on a piece of paper, but apparently those are complaints that OCR has received, and they want to figure out ways that people can get a hold of their record. Of course, if you have a portal that really has fulsome access to the record, including notes, and people are using that, presumably they won't be so interested in sitting in a doctor's office and, writing stuff down. But in any event, that would be an enhancement on the right of access. The government is concerned that, or has received complaints that when people request access to their record, they have to jump through hoops. And so they've said you can't have unreasonable barriers. You can't say, oh, if you file a written request for a copy of your record, it has to be notarized, feeling that tracking down a notary puts an undue burden on the patient. You can't say, well, the only way you can make a request is through the portal. Some people don't have access to portals or don't have computers at home. Having to say that you want to see your record in writing, or that you have to show up in person to see it, are all deemed unreasonable. And the inevitable question pops up, which is a good question. If they don't require something in writing, then how do you validate or prove that you're actually making the disclosure to the right person? Now, I suppose if you, although there wasn't a lot of guidance in the commentary on the proposed rule, I think they'll get a lot of comments on this point. I suppose that if you got a phone call that says, send me a copy of my record, the provider would, after doing some things to validate who they're talking to that they normally do, such as what's your address, what's your date of birth, and the kind of dance you go through before you're allowed to talk to a nurse practitioner on the phone. They would say, okay, we're going to send this to your home address. I think if somebody said, oh, I've got a new address, and it's an address that's only popped up in connection with fulfilling the record request, then I think the provider might be justified in wanting a little more validation around something like that. But I do think that is a tension that continues without this. I'll get to the one org to the other. Thank you.
David, do you think there's ever going to be any sort of best practice guidance around that, sort of at the industry level? Because it really puts us in a difficult situation. You know, people saying, oh, you know, you blocked my access to information because I called and wanted it immediately, and, you know, I couldn't validate who you are. And then, but on the other hand, if we give it out and it goes to the wrong person, like, you know, a former spouse or something, you know, and then we get sued because we, you know, released it to the wrong person.
As a complaint to OCR. So yeah. I think that, I think one thing that, I think there should be more guidance. And I think that could be accomplished, you know, I think frankly, industry could, I think there's still a few days left to comment on this rule. Let me just see.
They actually extended the comment period to May 6th.
There you go. Thank you. See, this is the problem with coming and making presentations here, is that half the people in the audience actually.
It just happened earlier this week, so no.
So wait, the law goes into effect April 5th, but the comment period goes through May.
No, not the info blocking law, the HIPAA law, the HIPAA rule.
And which is only a proposed rule. So if the comment period has been extended, you have a chance to get in comments. And I think that's a great, both number one, doing comments on this rule, which can be done online. The second, of course, is to go through, you know, some kind of healthcare industry related organization, if you can think of one, that could also reach out to people in government, either directly to OCR, which is probably the right answer, but also maybe to a sister agency like ONC. Denny, I don't know if you know anybody at ONC, but
Dave,
let me think about that.
We don't know anybody there. We'll have to think about that long and hard.
But I think it's a valid point, because it's a real tension in you know, what you want to do, right? Having kind of military grade authentication of people, and then saying, but you have to make this effortless and frictionless for consumers. And of course, those two things don't go together. And there are a couple of places where they just kind of run out of steam. They tell you, well, this is unreasonable, but they don't tell you what is reasonable. And that could either be done through sub-regulatory guidance or a change in this rule. Because I think if you had sub-regulatory guidance telling you it was okay, they would be very hard pressed then to do an OCR enforcement action based on something that they had blessed in a sub-regulatory document. One that I think will get enormous pushback The time limit for responding to a right of access request goes down to 15 days with one 15-day extension. I wouldn't be surprised if, assuming this rule goes final, that this is one where, you know, could get blown up. Just people saying now, their justification for it is they say many states now require a 15-day response. So ergo, we assume it must be doable because these various states wouldn't require it.
Well, that's actually part of the, I think to the point of the earlier person, and I apologize, I didn't catch who said that. There's actually two rules at play that kind of are a little bit opposed. There's the info blocking rule, which goes into effect on April 5th in like a week and a half, 2 weeks. And then there's the hipaa rule. And the info blocking rule itself, I believe, actually says something about 15 days, although I might be getting things mixed up myself.
I would have to go back and look at that. So, you know, and they did, I don't think they mentioned it in the commentary, but that doesn't mean you're not right.
I might be getting mixed up with, there's so many rules right now that it's possible I'm mistaken.
Yeah, well, you know, it's what happens when we sprint. We get out of breath and we have too many rules. There's a requirement to produce information in a form and format that's ideally mutually agreeable between the covered entity and the person requesting the data. They want to extend the form and format rule to personal health apps that use standards-based formats. I'm going to say more about personal health apps that come out later in this rule, in I think some concerning ways. There's, I think, almost, how many folks on this call have had experience with or used or encountered a request for data using a personal health app that is untethered from the hipaa universe, something that some third-party vendor has provided to a patient, and the patient is now saying, load this into my third-party health. I got one. Can you say a word about what that was?
Yeah, so there's a company out there called Swellbox, and they were targeting their market. You know, their marketing was to college students, and saying it was pretty in the early days was pretty interesting because they were asking college students to give them their username and password to the patient portal to, you know, allow them to download their medical record into Swellbox. So then, you know, you would have your records. In theory, they would collect your records from your, you know, primary care physician, a pediatrician, then college, and then when you go to graduate school, and it'd be all in one place. So
Wow.
they're still out there. They're still, I think, you know, working with the student population to try to encourage them to put all their medical records into the Swellbox repository.
Wow.
I'm sure, like Google, their motto is "Don't be evil."
Trust but verify.
Yeah, right. Hopefully with better security practices. I mean, you know, the security is one thing, and also, you know, I wonder what their privacy policy says. So that's, you know, to say, oh, just give us your password. I mean, that's just.
Yeah, I mean, we ultimately they were shut down on that, and you know, because of, I'm not a lawyer, right? Because of sort of who owns that credential and you know, student handbooks and all sorts of other things. So they quickly backed away when they were challenged about that practice.
Interesting. Yeah, and wow, mind-boggling. Yeah. Well, thank you very much. I think the comment I had on the tip of my tongue was, when you read this rule and you read the prior rules about APIs, there's somebody in the government, or at least who was in the government, maybe they still are, who had an almost religious belief about how all these apps are going to flourish and they're really going to improve the quality of healthcare and it's going to be wonderful. And, you know, the fact that they're not subject to HIPAA, well, don't worry about that. It's not really an important point. I don't know whether that point of view is going to prevail under the new OCR and with the new administration and a new ONC. But I think it's really something that comes through loud and clear in this proposed rule and in the last rule that has gone final.
They better figure it out quickly, given when the patient access APIs are required to be supported by payers.
Absolutely, absolutely. And they, I think this is one where if say Congress became energized, especially on the majority side right now, there's some strong privacy advocates, actually probably on both sides of the aisle in Congress, who might get a little excited about this if it was brought up to their attention. There's obviously only so many things they can get excised about in a particular period of time. Let's go to the next slide. And this was, I think, anticipating. Somebody was reading ahead. There would be more rulings around the verbiage around the right to direct copies of EPHI and an EHR be sent to a third party. One of the reasons this is coming up again in the rule is that there was litigation around whether or not OCR had gone too far the last time they proposed this in the high-tech rule, because they had also extended this right to paper records. And now this right only goes to electronic records that are an electronic health record, which more closely mimics the authorizing language in the HITECH Act. Again, such a request may be made orally, in writing, or via a personal health record, which I would call as a written request, in my humble opinion. And also, I think even more so, the right to, thank you, I see the comment. The right to require a current provider or health plan to request your PHI from another provider or health plan with a 15-day deadline, not to produce the information, but a 15-day deadline to make a request. In other words, I could go to my current provider and say, I got some care some time ago from this other provider. Could you please ask them to send my records? Or could you ask them, could you get my records from them? Or to do the same thing with a health plan. And then, of course, what do we have again? The authentication problem, right? The authority problem. The no one knows you're a dog on the internet problem. Tellingly not discussed in the commentary at all when it comes to this. And then they also invited comment and a new idea, which they call a broadcast request, where you could go to your provider and say, could you please find out who else has information about me, and broadcast that request across your I guess your network of contacts, maybe through an HIE, and see if you can vacuum up all of my information and incorporate it into your information. Now, of course, as I recall, the highway was going to kind of do that. And frankly, I've lost track of all the functionality in the Mass Highway at this point, whether they've actually, maybe Denny, whether they fully implemented this, or someone else knows on the call about the highway. The idea was there was going to be a directory and they were going to be able to find out, where's all the information about Dave. I haven't heard anything about that in quite a while, so I don't know where that sits. But, this strikes me as something, and I'd be interested in people's reactions. Let's create a right before there's necessarily an infrastructure to implement it. And, there may or may not be really an infrastructure that allows this to be done in a meaningful way without wasting a lot of energy. So I just want to look at the chat box here. Okay. Yep. Thank you. Notice of extension of the comment period. So, this sounds a little heroic to me. In terms of saying, oh yeah, well, this is just something we can do. Now, fortunately, it's not a proposal. It is an RFI, or a request for information, or request for comments. So that could also be fair game to talk about whether or not such a thing really should be made part of the right of access rule in HIPAA. Let's go to the next slide. You can see the right of access just keeps coming on and on and on. They're really concerned about it. They are horsing around with the fees. This is something, by the way, every couple of years, I write a little blurb for the Hospital Association about latest legal developments and copy fees. For those of you on the hospital side know that this has been a sore point especially with malpractice attorneys for a long time, including class action litigation against the hospital industry and a big settlement and then it changes in state law. So the fee proposals would be no fee permitted for access in person via portal or via an app. All other access rights would be based on the reasonable cost of copying and media, which the media should be very low if it's EPHI, but just for the labor in making copies, not for the labor in locating the information, not for the labor in assembling it, but simply the labor in making copies. And if a summary is requested, preparing a summary. It does not extend to the paper record. And this is a result of the case I mentioned before, Ciox v. Azar, where the court eviscerated OCR for going beyond their authority under the HITECH Act when it comes to copies. For those of you that are not familiar with the Ciox case, I'll just comment that it was brought by one of the many medical record copying companies that subcontract with hospitals and pass their fees along with the record request. So basically, this was I think almost every record copying company in the country was extremely unhappy with OCR and their approach on this. And this led to this litigation, which the government had to change course because of a federal court order. So they're trying to avoid, not evade Ciox by changing their rules and trying to make their rules as broad as possible within the confines of this court case, which interpreted their authority under the HITECH Act, which has not been amended. Next slide. If you have for fee schedules for copying, you need to post your copy fee schedule online. If you have a website, I'm trying to think of a provider that engages that has EHR that doesn't have a website. I haven't imagined one yet. A fee schedule for making copies should be available on request at the point of service. And the fee schedule should identify what are the free services, what are the disclosures subject to recovery of copying costs, disclosures via an authorization. And I suppose also you should disclose your fees for paper copies that are not delivered directly to the patient. And you should have a mechanism for giving fee estimates, like what's it going to cost to get my records, and being able to give someone a fee estimate on that. You are still allowed to collect the fee before you cough up the copies. They did not change that practice so that you don't have to produce the records and then chase somebody for, $273.27 or whatever the fee happens to be. Of course, with e-health records going out electronically, there's not going to be a fee associated with that anyhow. I assume they're hoping that over time, the fees are going to become less and less of an issue, but I don't think they're ever going to go away completely. Next slide. I get to take a breath.
Lynn, are you on with us?
Oh, there it goes. We'll be back.
This is a commercial break.
Hey, David, this is Sheila Joyce. I'll take advantage of the break.
Sure.
I put something in the notes, and it might be on one of your latest slides. Open notes, at least in my organization, there's a debate about it goes into effect in April, which is, in a couple of weeks, or now we're talking October. I think it's October 2022. Can't remember whether it's 21 or 22 October. Any insight or any opinion on?
There's nothing in there about open notes in this rule. So I have no update for you on that.
Okay.
I believe it's part of the info blocking rule, which is, as far as I know, still set to go on April 5th.
Well, Sheila, John here, we looked at it and have a different opinion about the requirement for open notes as it relates to info blocking.
Right.
I'm not a lawyer, right? But what I'm being told is, as long you don't have to make things available proactively. I think I forget the gentleman's name. Adam Green said that if you want to watch the video, we don't have to make it proactively available, but you do have to rapidly respond to the request. So one easy way to do that is to just put it out there and say, patient, go get it yourself if you want. Otherwise, we can print it for you. But you don't, as far as we can tell, you don't have to have open notes to meet the requirements going into effect next month.
But well, the info blocking is related to people requesting it.
Right.
So it has to be part of those requests. And so as of April 5th, my understanding is that anything that people request that is part of USCDI, you must supply.
Yes, absolutely. Absolutely. You need to supply it. Maybe I'm misinterpreting the concept of open notes. To me, the concept of open notes means I can go to a patient portal and just retrieve it myself without having to interact with anybody from the organization that provided it.
Right, you can do it on your own, yeah.
Oh,
Okay.
I see. I thought you meant the specific vendor that open notes.
No.
Apologies.
Sorry, yeah, no, believe me, it's just plenty confusing for me.
Yeah,
That's why we have David and others, Adam and others.
Yeah, and probably the assumption is, if you then may have to go around collecting this stuff, that eventually it's going to go in the other, people are going to default to just making it available automatically, but it doesn't happen by magic, the last I heard.
Thanks.
All right. But if there's more questions about that, I could root around and get the answer. So next one, please. There we go.
Okay, is Lynn back?
More to a question we came up with, or people have already been asking and thinking about. And again, I think the government hasn't really given enough guidance on this point. This is a huge problem, right? Is you have all this right of access, but then what do you do about identity verification and making sure the person is who they purport to be and they have the rights that they're trying to exercise. So identity verification is required, but it must be reasonable. Now, reasonable is a great word for lawyers because we use it all the time, right? The reasonable person standard, reasonable efforts, reasonable this, reasonable that. And often we can't quite explain it, but we feel it's like obscenity. We can't come up with a definition for it, but we'll know it when we see it. I think this is a really tough spot for everybody here. Specifically prohibited is notarized requests. They called that out again, or any requirement that all requests must be paid in person. Reasonable measures are permitted. That's okay, Lynn. Got your note. There's very little guidance in the rule about what is sufficient and what is excessive. Comments are requested, which is kind of what happens when the government runs out of gas when they're thinking about something. They say, well, give us comments, give us suggestions. It's a significant risk factor, in my view, and I think in the view of pretty much everybody who's said anything on this call. So, again, I think that would be a really good pushback point of saying, you got to give us more guidance. If you're going to open this box, we need a little more guidance about what we're allowed to do. I do think those phone chats about what's your address, what's your date of birth, what's the last 4 of your social, whatever it is, are going to become more frequent as people try to figure out ways to validate identity. Maybe looking at what some other industries do, financial services do, is probably not a bad idea. But, part of the challenge here is trying to open up the system to folks that don't have smartphones, that don't necessarily live on the computer, live on the internet all day, and trying to make it frictionless for them when maybe they're making telephone requests, yet avoiding people that are literally trying to steal information. And then the comment is correct about financial services uses other kinds of data. And I know health providers who have used that as well, using service providers that, you have a variety of data. You put it together in a way that gives you a fairly high assurance that someone is who they think, who they're purporting to be. You don't have to be perfect, but you do need to have a good system. And I do think it's a significant risk factor if you just say, well, they want us to open the door, so we're going to open the door and make it frictionless. I think this area needs more work. Let's go to the next slide. Thank you. And that is the end of the right of access, which I think, you know, as we just heard, has a couple of problematic issues. I think this will be a lot less problematic. They are trying to both slightly change the rules and provide a clarification of what the law probably has already been for a long time around care coordination and case management. So what they've talked about in the commentary is that both of these things can be performed either at an individual level, at a population level. And historically under the rule, a provider has always been allowed to perform case management or care coordination for individuals, and that's considered treatment, right? And as we know, treatment is the most favored use of PHI. It has the least restrictions on it. If you're doing something for treatment, you're not subject to the minimum necessary use rule. The government is much less likely to second guess the use or disclosures as long as it has a reasonable relationship to the delivery of treatment, you know, diagnosis included, to the individual. Both providers and health plans are already allowed to perform these functions on a population, but following the rules for healthcare operations, which does include minimum necessary use, and is a little more restricted box of how you can use and disclose protected health information. I'll get to that question in a second if I can figure out what the answer is. OCR wants to amend the definition to make it clear that a health plan can perform care coordination and care management for individuals as part of healthcare operations. Now, I will give an editorial comment saying around 11 years ago, I was diagnosed with a troublesome healthcare condition that required me to get some therapy, and it continues to require me to take medication every day. I got terrific support from my provider, from my doctor, from specialists, from nurse practitioners that work with my doctor. To the point when I was first being taken care of, I got calls every 2 or 3 days. How's it going? How's your medicine? Et cetera, et cetera. Then about a year later, I started getting calls from someone associated with my health plan that wanted to talk to me about it, but knew very little about really what was going on. And I was expected to be on the phone educating them about my condition and my medications and a bunch of other stuff. And my personal reaction, this is really, what's the word, superfluous. I don't need another layer of time spent educating someone who works for my health plan or is a contractor to my health plan about my case management. So I didn't find it useful, but it may be that there will be people that really will find it useful, or the plans may find more efficient ways to implement it. So ends the editorial comment. But they've made it clear that this is a permitted use of PHI, performing care coordination and care management for individuals. And the government is extremely interested in having more care coordination across providers, across settings of care. This is not new to you, of working through the chain of acute, post-acute, chronic, social services, and a lot of other things. Is a way to make care more efficient, make it better, and make it more affordable. So they wanted to make that expansion. I think that is a change. That fourth bullet is a change in the law, and especially the last bullet on this slide is definitely a change in the law, that these activities carried out by a plan on individuals would not be subject to minimum necessary use. So they're kind of recognizing what's the difference between care coordination and treatment. It may not be much of a difference, or it may be a difference that's very hard to parse out. So we're not going to apply minimum necessary use to these activities aimed at individuals to coordinate their care or manage their care in different settings. I think that is probably the big contribution to kind of value-based care that's in these rules. Why don't we go to the next slide? As I mentioned, both plans and providers would have greater leeway to disclose PHI to a third party that provides health-related social services. Today, it's fine to disclose for treatment purposes to a provider, even if they're not a covered entity. So the information doesn't have to be locked up in covered entities. You could disclose to a provider who is not a covered entity. Here now, we're more explicitly making it clear there can be disclosures to social service entities that are not healthcare providers in any way, shape, or form. And so that could be a food service, it could be Meals on Wheels, it could be a sheltered housing program, it could be someone who is doing other kinds of social services. They could be related to behavioral health, they could be related to substance abuse, substance use disorders, or other programs for people with disabilities, people, for elders, where you're getting now more into also maybe the social determinants of health and bringing them more into the circle of trust for the sharing of protected health information for the purposes of providing these services. So go ahead.
Do they have the same responsibility and penalties for protection or lack thereof?
Not under HIPAA, because they're not CEs.
Right.
But you're not responsible for what they do. I mean, if they screw up and publish the stuff on the internet, that is not your responsibility. And I think that's clear.
But if they screw up and publish it on the internet, they're not held to the same legal liability as we are?
Well, they're not held to HIPAA.
Okay.
There can be other things, bad things that happen to them, depending on what's disclosed and the consequences. And for example, in this state, you have our general privacy law that says everybody should be free of a substantial or serious invasion of their privacy. And in connection with the court can have injunctive relief or order damages. And I just recited the whole law, by the way. That's pretty much it. So there are other bad things that can happen to them, and they may very well have privacy obligations in connection with their own permits that they get for the services they do or the grants they receive and things like that. Have I researched that down to the, ripped out the studs and looked at the basis for it? No, but I think you can probably assume that they have their own privacy obligations that they have to honor, but they're not covered entities. So they don't necessarily follow the rules that we do. I worked on setting up one of the model AACOs in this state. A lot of you are familiar with the Mass Health ACO program. The whole idea of transitional services, support services, social services being wrapped up into the ACO program is inherent there for people with chronic illness and other things. This is, I think, a welcome change because we were always jumping through a lot of hoops. Can we send this entity a list of our patients? Can we do this? Can we disclose that? And I don't know, what consent do we need? What authorization do we need? This is a big help. And this is something I think the government really wants to do. Now I'm going to go back to the chat and see if I can. The question is, does this remove all patient consent requirements? I think it certainly eliminates any idea that you need an authorization under HIPAA. I think that's clear, and you can make the disclosures. Now, whether you want to have a consent so that the person knows their information is being transmitted or for other purposes, it may depend on what kind, it may also depend on what kind of information. Since I've mentioned, and I will mention later, of substance use disorder treatment, there is nothing in this rule that modifies the Part 2 rules for records of substance use treatment. So if your system of supports includes a Part 2 program, right, like detox or rehab for substance use, you've still got those folks still have to follow Part 2. And if you get a record from one of those programs, not information about substance use that you have elicited from the patient, but you say, here's a record from the detox program at DMIC, you have to protect it in accordance and only disclose it in accordance with the Part 2 rules. Have we eliminated all the friction around that data? No, we have not. I think it's a disappointment to me, given the crucial importance of improving treatment of substance use disorders, but the law is the law and I don't write it. As to specific consents for specific kinds of releases, that may be based on the context or the specific kind of provider you have. But I think from a HIPAA point of view, you've got a lot more flexibility if this rule goes into effect, which it has not. Let's go to the next page. And again, the heading here is individuals with substance use disorder. These comments also apply to serious mental illness. OCR proposes changes to put more disclosure to family members of individuals who are being treated for substance use or for serious mental illness. Providers now only have to have a good faith belief that the disclosure is in the best interest of the patient. I think the current rule is just a bit stricter than that. Again, this does not amend or relax any requirements under Part 2. It also does not amend or relax any requirements under state law. And with a substance use disorder for serious mental illness, we do have what lawyers like to call these sensitive data rules, sensitive health information rules around behavioral health, around substance use disorder, that are going to continue to apply no matter what OCR says. So having to go through that kind of matrix of what does HIPAA say, what do the social worker regulations say, what are the rules of the Board of Registration and Psychology say, what are the regulations that apply to behavioral health facilities say, we still have to go through all that exercise. So we don't have frictionless transmission of this kinds of data throughout the system yet. We may never get there. OCR states that they received significant pushback on these proposals when they were talking to some stakeholders in the behavioral health arena who aren't happy with what's even been done already to liberalize Part 2 and would continue to push back on any further changes to the Part 2 rules for understandable reasons. But I think it's a judgment call as to what really needs to be done with some of these privacy rules. Why don't we go to the next slide? The NPP, everybody's favorite thing. I can remember way back before my beard turned gray when I spent a lot of time looking at people's NPPs or answering questions about NPPs. They seem very important and mysterious. Now, not so much, people don't care about them so much. It's well understood. As I said, providers would no longer be required to collect the acknowledgement of receipt of the NPP. One useless paperwork burden eliminated. However, the NPP would be changed, so everyone would have to come up with new ones, stating that the individual would have the right to discuss it with a person designated by the covered entity and provide the location or contact, and contact information for that individual. So, lucky people that will be designated to answer the questions. Presumably it would be the privacy officer or the privacy officer's staff that would be charged with answering questions about the NPP. But that now that function should already exist in an organization. Now it's going to get called out in the notice. A new header would be required, which I've not reproduced here, which basically would say this is not only about how we protect your information and uses and disclosures, but it's also about your access rights, and kind of expand the title of the notice to cover more territory, and I think this is reflecting OCR continuing to be on the warpath about access rights. They want to call them out more in the NPP. You would have to include information on the enhanced access rights in the notice of privacy practice, and optional to include information on the right to direct PHI to be sent to a third party. Again, this is something the government has been concerned about for a while, and they're thinking about making it an option to put it in the NPP. Does that mean someday it'll be a requirement? Maybe. Frankly, I think the government has more faith in the value of this document than it has in the real world. I can remember when government officials would say, oh, this will create a moment between the provider and the patient where there will be a meaningful discussion about privacy rights. Not so much in my experience, but it's something, it's beloved, and it's somewhat magical in my view in the eyes of the government. Let's go to the next slide. TRS, this is not a big deal. Telecommunications relay is things like having translation services online where the person can talk through the TRS service and get an instantaneously translation for the purposes of communicating health information. It can be used by providers to meet their requirements for limited English proficiency and for some other purposes. There's always been sub-regulatory guidance that a TRS service is not a business associate, that you can just use them and you don't need an agreement with them to do it. They just want to put it in the rule and maybe expand it a little bit, try to make that a little less friction on that relationship. Not a major change in the law, arguably not really not a change in practice at all, I don't think, just a little change in the law. Out of breath, what's next? All right, let me stop there and ask if there are any other questions about this HIPAA stuff. I do encourage with the change in deadlines, submit your comments, even if they're pithy and short. They are required by law to look at the comments. They will get published. You may, if they get a lot of comments on a particular issue that are thoughtful, it may well cause them to change course. And I do think whoever's looking at this may very well not be the same person who drafted it, or their supervisor may not be the person. So I think it gives a little more leverage to change or delay troublesome aspects of this rule.
David, this is Bill Young. Wondering if you could talk a little bit more about sharing the Part 2 data with providers within the care group or within our sphere, right? All of my, healthcare providers connected to me. Is there any changes to that?
There's been no changes announced on this on Part 2 rules. If you, and again, I think one of the big areas of clarification that came out in some of the more recent rulemaking around Part 2 is that if you are operating a general medical facility, not a dedicated substance use program, but a general facility, and you elicit from the patient information about their history or current problems with substance use, that is not Part 2 data. Just because you found out that the person, has been recently treated for addiction or is in recovery or should be in recovery, maybe it's why they presented at your emergency room, that is not Part 2 data subject to the Part 2 rules. If you run a unit or program that is held out to the world as this is our facilities or our health systems substance use treatment or diagnosis program, that program probably should be complying with Part 2. And then you have the question of putting everything in a nice box of enhanced privacy and security for that program. But if you're talking about a general medical facility, the only thing where you have to worry about the Part 2 rules is information you actually receive from a program, like a detox program down the street, where they say, well, we're sending you, we've got permission from the patient to send you this report, or we're sending it to you because you've identified an emergency where you need it to save the life of the patient, something like that. I don't know if I'm addressing your question, but none of this.
You are, David, in an organization like, maybe give you my example. So we are an organization that goes from primary care to neurosurgery, and in the middle there is behavioral health. And primary care providers especially are saying how important that data is to them to care for the patient. And really, this hasn't changed any of that. I still have to lock down that Part 2 data, even from the primary care doc treating the patient. Is that true?
If it's data from a program. In other words, if the primary care doctor sits with the patient and they're not holding themselves out to the world as a substance use specialist, and we know that a lot of substance use treatment occurs in the primary care setting.
Yes.
People see the doctor. And that data is not Part 2 data. It's maybe red hot private data, but it's still governed by HIPAA and not by HIPAA and Part 2. So they can disclose it. Go ahead.
Having an actual unit like that data coming directly from that unit, still has to be kind of locked away unless
Yeah.
all the right
Yeah.
signs and
So you might
signatures
need- you
allow
might-
it to flow.
You might need a consent to move that
Yeah.
report on that came from the part two program. And hopefully
Yep.
if they're a program, they know they're a program, because there's a lot of other things that go along with it. Special consent forms, tweaks to business associate agreements and all that kind of stuff.
Yep. Yep.
You know, I wish it was
Thank
easy.
you. Thank you.
I wish it was easier. You're welcome. There has been very strong pushback from the specialized provider community on any attempt to liberalize the Part 2 rules. And, you know, I think it's all in good faith. It's something that the healthcare kind of, you know, the system has to work out over time. See if I've got a new chat here. Okay, yep. Let's go to the next one. Burden reduction, he said, with his tongue firmly planted in his cheek, but this is what they call it. Now, it is burden reduction, but not for the providers, I think. Maybe it is, in the long run, going to be burden reduction for providers. Another HIPAA question. Go ahead. Does HIPAA address whether providers can record or maintain transcripts of telehealth calls? I'm going to open the whole thing. Given they don't do anything analogous to on-site care. Yeah, so the question is, can a provider record a telemedicine visit? And I think the answer is, well, I don't think. The answer is yes. And of course, a lot of these systems are set up with a record option, or maybe even a record default. If you do record it, number one, you need to comply with your state law. Massachusetts is a two-party consent state. So if I record something and somebody doesn't know it's getting recorded, that is potentially a violation of the state wiretapping statute. So both sides of the conversation are supposed to know and consent that it's being recorded. And of course, that's when you call Fidelity, who basically owns everything that's not in the healthcare system. This call is being recorded for quality purposes, blah, blah, blah. So you get off the call if you don't want it to be recorded. So that's one, but number two, yes. But once you have that recording, there's PHI in there, and you've got to secure it and protect it just like any other kind of electronic data that is, that you might hold. And I think there are just, I won't say I have a definitive recommendation on that, but I think it requires a little reflection of what kind of information do you want to maintain in the long term. If people are going to go back to that recording as part of treatment, say to help manage the person's care, I'm going to listen to that session again, you risk making it part of the designated record set, which I think would be enormously troublesome. To say the designated record set now records a video visit. Secondly, a concern I would have is that, what's the biggest use of telehealth? Probably the number one use has been during the crisis, has been behavioral health. And boy, those recorded sessions could be, as red hot possibly as written process notes that a therapist doesn't even put in the electronic health record. So I would want to do a little bit of, I think, is it permissible to record if you follow state law? Yes. If you follow HIPAA to protect it and secure it, that's what you have to do. Do you want to have a recording of a visit, of a session that especially could, include the exchange of behavioral health information, other kinds of red hot private data? I think that should be an extremely intentional decision. Now, whether you would maybe say we record it so that someone on the provider side can go listen to it, extract what needs to go into the system, that's another thought. So I think that's probably a seminar in and of itself. A transcript of a telehealth call, if you make a transcript of that call, it's probably going to end up going in the record. It becomes part of the designated record set. Does it have information in there that you might feel you need to more closely guard? Again, I think for behavioral health, that's a real interesting question about how you really want to manage something for behavioral health visits. You know, you've got rules around social worker data, disclosures to social workers that are more tightly regulated, frankly, than disclosures to doctors in some way. So I think all of that needs to be taken into account. There was another question in here, bear with me.
Someone asked about, oh, okay, sorry, I thought you missed that.
No, I'm trying to keep up. SMS messages complaining PHI need to be HIPAA compliant. If the question is, do they need to be secure? Do you need to have some reason to believe that this is a secure channel of transmission? The answer is yes. I think if you receive SMS messages from the patient and they contain health information that you think needs to be part of the record, then you need to figure out a way to import them into the health record so they become part of the designated record set. I'll give you an analogy. I recently went through some training at my law firm about text messaging with clients. And, you know, it's highly encouraged to use text messaging with clients to say things like, I'm going to be 5 minutes late to our phone call, or I'll get back to you as soon as I can, or I have some important information and I haven't been able to reach you by telephone. This is going to sound very familiar. That's fine. There's a real concern at our firm, even though it happens, about getting protected attorney-client privilege information that is important to keep track of by text message, because then the question is, well, how do we make sure then that message is preserved if it's really important information in our record-keeping system, which is not interoperate with text messaging. At least I haven't tried to make it do so. And how do we make sure that message is confidential from a privilege point of view? Although we do communicate with email all the time, but we warn clients that email is not necessarily completely secure. And we do use encrypted email in my practice for some purposes. So, but do you need to have a secure channel when you communicate electronically? That hasn't, the security rule applies to SMS just the way it would apply to email or anything else. If you're going to text message with a patient, I think you need to warn them, this isn't necessarily as secure, you know, as you might like. And I am not up to date on how secure, say, digital text messaging is in transit. My guess is it's probably pretty darn secure, but you know, those would be the array of questions I would consider. I'm going to close this window. So, Medicaid burden reduction. This rule applies to fee-for-service Medicaid programs, fee-for-service CHIP, MCOs, managed care, managed Medicaid, and managed CHIP, and ACA plans that are offered on federal exchanges. I don't think that applies, therefore, to our ACA plans in this state because we have a state-run exchange as opposed to a federal exchange that connects to the state. I'd be interested if anybody disagrees with that or has a question about that. But at least this is a Medicaid and CHIP rule in this state and more so in other states.
I thought the state-run exchanges were considered part of the federal exchange program.
They're certainly part of the ACA and get all the subsidies and all that, but there is a distinction in the rule between state-run exchanges and federal. And that would be something, frankly, I didn't dig into before I prepared this deck. So if there is different information on there, especially the plans are going to want to understand it to figure out whether they're going to be subject to this rule for, you know, for more than just managed Medicaid and managed CHIP. Excuse me. That is not COVID. I'm just clearing my throat. So the idea of this rule is to facilitate transfer of information, especially when patients are changing among different plans, as the government now calls that churn as well, and especially the idea of someone going from Medicaid to an exchange, back to Medicaid, you know, and the like. I think the government didn't feel they have jurisdiction to set the rules for the state exchanges in this way, although it's an interesting question legally whether they could do that or not. There are also a whole bunch of RFIs in this NPRM, and I don't go through them all, but requests for information. And a big part of this rule is around prior auth data. They really want, especially either existing authorizations or pending PA requests, that if the patient changes plans, that that information will be readily available to the successor plan. Let's go to the next slide. And I have to say, I went through this a little more quickly than the HIPAA stuff. So there may be areas where people on this call actually know more than I do, which is not unusual, by the way. So they want to, first of all, in prior rules, they said, we're going to recommend the use of implementation guidance from ONC, the implementation guides that ONC has been producing. And for all I know, Mickey is busy writing one right now, that we're going to have another implementation guide from ONC. They're changing the rules to require that, I think because they felt that their recommendations didn't have the force of law and that there was a little bit of a gap between what ONC was doing and what CMS was requiring. So they're trying to close that gap. So they're going to require the use of any ONC guidance regarding information about pending and active prior authorization decisions. There would have to be a process for attestations around third-party apps regarding privacy practices. That's very interesting to me, and I'm going to talk about it more. They're going to, for APIs and requests around prior auth, there are going to be reporting requirements to CMS. How are you using it? How many requests did you get? I think on fulfillment of the requests. There's going to be an implementation guide for the provider directory API that's already been mandated by prior rulemaking. Again, they're trying to tighten up the relationship between ONC and CMS on this topic. And they want more payer-to-payer data exchange between Medicaid and CHIP fee-for-service programs. So if someone is changing from, I'm thinking about that a little bit as I read the bullet. I'm wondering if I got that right, but let's keep moving on. Let's go to the next slide. So no surprise, they say we're going to use HL7, the FHIR-based APIs, which is already what they've required in other rulemaking on this topic. They are going to require the payers that are subject to this rule will have to run a documentation requirements lookup service for prior authorization, so that the information about what you need to submit for prior authorization and for different kinds of authorizations is going to be more available on a lookup service. Now, I am ignorant as to whether this is something that's readily available today, but there's going to be a uniform requirement on this, and there's going to be a guidance on that, again, coming from ONC, but will become a CMS requirement when it's adopted by ONC. Provider use of the API for prior auth would be voluntary. So the plan has to author it. The provider doesn't necessarily have to use it. And Danny, I assume that this is something that Meehan has been looking at fairly intensely.
It is, David. I'll defer the detail to Dave Delano, who's managing this project for us. But yes, we are in the process of standing up a prior authorization, e-prior authorization prototype. And this new term, documentations requirements lookup service, I think is the latest of a compound noun phrase that the federal government uses to describe what were in the Da Vinci guides, two separate implementation guides for prior auth. Dave Delano, any comments from your end?
Yeah, there's another component called coverage, CRD coverage requirements discovery, and then documentation requirements lookup service. The way the rule is written, the Da Vinci guide separates the two, but the way the proposed rule, and I say proposed rule because I think, David, there's currently a delay, a 60-day waiting period for this rule to actually become finalized. We haven't seen from our side any additional opportunities for comment on this rule, but I think the expectation is that there will be an extended or new comment period. At least we're hoping there is, because there's lots of comments about it. But we're trying to figure out how to implement this, Dave. There is not a standardized way to do a documentation requirement lookup service out in the market today. There's a bunch of vendors that provide some services that sort of mimic this or behave similar to it. But it is a new concept, and we are trying to figure out exactly what it means and how to implement it.
And this is Janice Karen. If I could comment, the other components of the law that are not, of the rule that are not specifically the prior authorization request we're exploring under the data governance collaborative. That's the changes to payer exchange from the previous rule that required peer-to-payer, the payer-to-provider APIs, and the changes to the patient access APIs are all being looked at under the data governance collaborative.
Very good. Yeah, for the, just, again, in terms of scope, kind of the other side of what I said before about who this applies to, the government is at pains to point out this does not apply to Medicare fee-for-service. So this will not become an instruction for Medicare contractors under fee-for-service, and is not a Medicare Advantage requirement at this time. But again, who knows what the future may hold.
David, could you share a little bit of, even if it's interpretive, why these programs have been excluded? The Medicare fee-for-service and Medicare Advantage.
I think it's probably more just the focus they've had on Medicaid and this latest. This is kind of, I would look at this as an extension of the last rule, which also, as I recall, did not apply to Medicare fee-for-service or Medicare Advantage. I think that's as much as smart thinking as I can produce on this. It's just an extension of what they've been doing before. I think there's a whole different regulatory infrastructure they have to deal with for pushing out a new Medicare fee-for-service program. And then MA, it might have to be part of, again, the cycle for MA contract renewal, I am guessing. But it's really a whole different segment within CMS. So that's the best I can say. Are you saying, I'm not saying that the kinds of concerns shouldn't be of concern to the MA program or to Medicare fee-for-service. I just, the differences in the administrative infrastructure around these are significant. To your point about the compound nouns, I assume that this rule was originally written in German and then translated into English, and that's why we see these big enormous compound.
Oh yeah, it was definitely.
It was translated
French.
from.
Maybe it was written in French. I don't know.
But by 3 different translators who didn't talk to each other and therefore contradicted each other in different places.
Yeah, as they say, it sounded better in the original German.
I think one of the issues that I heard alluded to regarding the Medicare fee-for-service, less so with Medicare Advantages, there are also the dual eligible programs that are, where Medicare and Medicaid are coming together, and those add additional significant complexities to this kind of thing.
As if the system wasn't complicated enough.
Right.
And if there's another gap filling program from the Biden administration, we'll probably have yet another thing to put into the jigsaw puzzle. Maybe they'll just expand one of the existing programs.
Yeah, the biggest oxymoron in all this, David, is the burden reduction title they've put on it. Because honestly, initially, this is going to increase burden because people will be trying to figure out how to manage, those plans that are not, required to do this versus those that are. So initially, it creates another pot of data and administrative burden that we have to manage. But,
no question. Mm-hmm. So let's go to the next slide. See if I know anything here. Prior auth timeframes for Medicaid MCO, 14 days with one extension of 14 days through December 31st, 2022. Subsequently, 7 days with one extension of up to 14 days. And I think those are for routine requests, not emergency requests. For Medicaid agencies, for fee-for-service Medicaid, 72 hours for the expedited request and 7 days for a standard request with one extension of up to 14 days. Who might push back on this? The Medicaid MCOs? I don't know. I have no idea, by the way, how this compares to what people experiences out in the field for PA responses. I would expect the state Medicaid agencies to say, well, this is going to cost us money. Is this something we're going to get? You know, the Fed's going to pay this through, you know, the 90% share, the 50% share, or whatever, in terms of quicker turnaround. And again, I don't know what people's actual in the field experience is with PA timeframes for results. So if anyone can speak to that.
Yeah, it seems pretty generous to me, Dave. I mean, that's me speaking as a person who hasn't actually processed a prior authorization in my lifetime, but but knowing a lot of folks that do and have spoken with a lot of folks that do, this seems reasonable in terms of a turnaround time, as long as the information is provided. When you start getting into back and forth, you know, oh, we need additional information, this is pended as a result of needing more information, it could extend beyond, you know, this time window. But as long as the initial response, I think, is what they're looking for, right?
Yeah.
Is the,
And given how much of the process is hopefully automated under the new program, it seems somewhat generous, actually.
yeah, I would agree.
That's good to hear.
Yeah.
And hence the lookup service, right? Supposedly it'll,
right,
in theory, maybe eliminate a cycle of rework or supplemental information.
Correct.
You know,
Only if the providers adopt it, though.
Oh yeah, no, this is
So
a two-way.
It only works that way.
Absolutely, Kim. This is a two-way street for sure, and it requires, you know, adoption on both sides, which is what the pilot project that Danny references that we're working on, is to figure out the workflows, the integrations, the technology, and the data exchange, and essentially the services that need to be stood up to support this. So it's not a simple endeavor, but hence why we're tackling it.
Go to the next one. Here's my favorite, the privacy attestation for apps. CMS reiterates they cannot regulate the private app developers. But here's the new proposal. If a patient/member authorizes the release of information to an app, the plan would then be required to request a privacy policy attestation from the app developer or the app vendor, in which the developer would have to provide an attestation around certain information. And then CMS sets a minimum standard for the attestation. If no attestation, however, is received, if you send out the request and you get radio silence, or the attestation is defective or incomplete in some member, the plan is supposed to notify the member. And if the member then revokes their permission, no PHI is released. If you get radio silence from the member, or the member confirms their permission, then the PHI must be released to the app. Okay, speaking as someone maybe who has spent too much time thinking about privacy rights, I think this is really defective.
It's a vast improvement over what was there in the first rule.
I guess I'll accept that one. I will accept, but particularly the idea if there's radio, if the app person doesn't, if the app vendor doesn't respond, and the member doesn't respond, then you still release the PHI. I'm not a fan.
No.
Yeah. There are clearly issues around this, but the first version of the rule, the one that goes into place this July, so during the period from July until this goes into place, assuming it's adopted, they have to send it for any request there's no attestation process. And if it's requested, if the patient approves the request, they have to send it no matter what.
Right. And that would still be true under both models, but at least here you get, I agree this is an improvement, but you know, I would still tend to send it back with a grade of incomplete. Let's go to the next slide. So here are the topics for the attestation. Is your privacy policy publicly available and shared with the member prior to the member granting permission? Kind of a yes or no question. Does the policy address access, exchange, or use of PHI with any other person, and it should say is prior consent required for further onward use of the information. I think it's also supposed to address whether the information could be sold. Will the app access other information on the consumer's device? I think we know the answer to that one is yes. How can the patient discontinue app access to their PHI? And what is the process of disposing of data once consent is withdrawn? And again, there are no standards. In other words, there isn't a right or wrong answer to any of these questions other than what the consumer judges is right or wrong. Okay, I understand that as a philosophy, but there's not even really a requirement that they answer this fully, which I think is really problematic. The NPRM CMS says, and this is probably true, they do not have the right to mandate the consent of the privacy policy. I would think perhaps the Federal Trade Commission could do so through rulemaking. They haven't done so. Maybe that time will come around. The other alternative would be that Congress actually gives OCR more authority to regulate this area through the HIPAA regulations. Yeah, do we know if this is going to come from a mobile app? It doesn't have to be. It's kind of, again, I think that there's an assumption that this might be something embedded, an app on a smartphone or an app on an individual's, say, desktop computer. But I don't think that's mandated. I don't think there's anything that necessarily makes that true. So it could come, from the vendor system where they represent that they have the individual's consent. The rules around authentication are thin here. I just find this a little troublesome. I'll say more than a little bit troublesome, but I don't make the laws, as a lot of you may have noticed.
Hey, Dave.
Yeah.
Isn't it true there are some FCC regulations or other governing regulations around all this?
FTC, Federal Trade Commission, has the authority to clamp down on any unfair or deceptive acts or practices that are outside of HIPAA. And they do have a rule about personal health record apps doing breach notification. I haven't heard too much about enforcement or reported breaches in that space. So they do have jurisdiction. I don't believe, and I didn't run it down to check, but I think I would have heard if the Federal Trade Commission had actually engaged in rulemaking in this space. They do have the authority to engage in rulemaking. A lot of the way they proceed, however, is they often make rules through adjudication. What I mean by that is they bring a case against somebody, and then as part of the resolution of that case, they kind of announce to the world, well, by the way, from now on, our policy is A, B, C, X, Y, Z, and that's what we expect everybody to do. And that's kind of like the difference between the LabMD litigation by the FTC and a HIPAA privacy or security investigation by OCR. OCR has, fulsome security rules. The FTC has some guidance, but they do a lot of rulemaking by litigation. So the short answer is nothing like you're used to seeing in HIPAA. Although certainly if one of these app providers had a privacy policy and didn't live up to it, or actually did the exact reverse, they would be violating the Federal Trade Commission Act. And then the question is, would the FTC find out about it and go after them? So, we shouldn't say that there's no law here, that there's a complete Wild West situation, but it's less detailed and prescriptive than those of us that are used to HIPAA experience on a regular basis.
Thanks.
Let's go to the next one. Right, there you go. The NPRM does not make health plans responsible for uses and disclosure by the app. They made that clear in the last rule. It's not changed in this notice of proposed rulemaking. The app developers are not regulated in any way directly. It's really kind of an indirect regulation that the health plan will ask them a question and then go back to the member/customer. But there's no direct applicant regulation here. And as of December 18th, when this was published, CMS had not backed away from the idea that the patients are responsible for making these decisions, even if the private policy is incomplete or non-existent or discloses risky uses of data. So I think the philosophy is simply different, is the best way to put it. We're going to put all the rights and controls with the individual. We could have a discussion about whether that's the best way to do it or that it creates new risks, but that is clearly the philosophy. Will that be the philosophy of the Biden administration? So far they haven't done anything to cut back the original rule that allowed this. So I guess, more to come, maybe, or maybe not. Big uncertain area as far as I'm concerned. Let's go to the next slide. That's it. There's a lot more technical detail in this rule and a lot about burdens and costs and stuff which I didn't get into. So I commend the proposed rule to you. And also we all need to keep alert as to whether this continues down the path of becoming a rule. It would not be the first time that a NPRM had failed to graduate to a final rule. That has happened before. Some NPRMs have hovered in rural cyberspace for a long time, and it takes them a long time to become final. Or when they become final, there's a whole nother round of changes. So, I would say this is all interim, this is all proposed, and stay tuned. Any other questions?
Yeah, actually, a quick comment about that, and then a question that you had said you would loop back to earlier. There was a final rule that got put out there, but it was frozen. So we're hopeful that it does on the burden reduction side, not the HIPAA side. And so we're hopeful that there will be some additional comment periods and that allow for some additional changes before it becomes final. But there is some thought out there that it is likely to become final fairly soon. So hopefully there will be that comment period and the ability to make some changes, because that rule happened so quickly that there are actually inconsistencies and like some real issues with some of the sections of the rule.
Yep.
Going back to, I had asked a question earlier in the chat that you said you would come back to. Let me rephrase it slightly and ask it verbally, if that's okay.
Yeah, sure. Of
And
course.
that is, do you see further changes to the minimum necessary clauses to align better with the upcoming provider requirements to send all US CDI data to the payers, or are the current changes sufficient?
Well, I think that if something is a required disclosure, that satisfies MNU. In other words, if the law says produce this data, and I think this, most of HIPAA, other than disclosures to the Secretary of Health and Human Services and a few other things, most of HIPAA is just a permission. In other words, even like fulfilling an authorization, you're actually not required to fulfill an authorization. You are allowed to once you receive a written, a valid authorization. My quick reaction, although I'd be happy to look at it and update everybody, is that if the rule says thou shall produce this information in a data set and send it on its way, that probably satisfies a minimum necessary use. Just in the same way, you don't have to think about minimum necessary use when you're fulfilling an authorization. The authorization in its four corners tells you what data produce, and you just produce that. You have permission to produce that data. Here, if it's a requirement, I think that MNU is satisfied by doing what the rule allows. But I could take a quick look back at that and confirm that, but that's my quick reaction.
I know there have been a lot of questions around that from the membership, so that certainly would be helpful.
Let me make a note. I'm actually writing something down. Okay.
Yeah. Hey, Dave, I had one quick question / comment about the proposed HIPAA rules, which came up on the prior authorization Da Vinci work group that I sit on. And that was related to the X12 messaging standards and whether in some use cases now, particularly with API exchanges coming into play for things like prior authorization, that are requiring other uses beyond the X12 message types, which are the HIPAA mandated message types. Have you seen, or does anybody know if there's been any discussion about relaxing those requirements of the use of X12 messages for those specific burden reduction use cases that are in the proposed rule? I haven't heard or seen any HIPAA proposed changes around that, but I think there's some rumors out there that they're floating around. Just wondering if you've heard.
I have not seen anything on that.
Okay.
Yeah. Have you heard of any further changes in general beyond this initial proposed rule? Because one of the things that I had heard was this proposed rule was meant to make enforcement or implementation of the CMS NO&C rules that came out both in May of 2020 and the one that we're discussing today, which in theory came out this January but is now frozen. That a lot of the changes in the HIPAA rule were designed to bring things into alignment, and I don't see that so much in what I've seen about the HIPAA rule, although I have not read the whole thing myself.
Yeah, I think maybe at a high level, the HIPAA rule is around care coordination and patient access to data. And so, I think maybe the authors of this, who were in the government last year, would say it's all part of a common plan to make information flow to patients through apps, information to follow the patient as they change plans, information to flow through the provider system more for social service purposes and for some of the other things outlined in this rule. But in terms of them really being kind of a piece and really fitting together in a tight way, I would say no. I think it's more of maybe a common motivating philosophy about increasing the flow of information around various actors, if I'm understanding your question properly, but I don't think they're tightly bound to each other.
Okay, thanks. I don't want to take time away if other people have questions, but I have some more if other folks don't want to speak up.
Well, I just have one question or comment, which is, under SEMA Verma, CMS basically said, let the data be free and let consumers decide what apps they want to use. Let the market determine what constitutes appropriate use of health information. And behind that, we have this fairly longstanding legal infrastructure about what constitutes protected health information, about what constitutes appropriate use. And it seems to me, David, and correct me if I'm wrong, that I don't see a future where app developers with personal health apps are not going to be certified in some way. Consumers are going to want to know that. I would think it would even be a competitive advantage for those app developers to say, we have the check, much like the high trust stamp or some kind of equivalent, clarification that if you share your data with us, we are going to be, belt and suspenders in support of protecting that, rather than we're going to mix it with the data on your machine. We're going to tie it to your Facebook app, and we're going to do all sorts of interesting things that you don't know about. Do you have any thoughts about that? There seems to be this gap between sort of the political philosophy of the prior administration, as evidenced in the rules, and what really needs to happen in terms of protecting privacy in these apps.
Yeah, I agree with. I think first of all, your comment is right on about maybe a change to some degree in the political philosophy around it, animating the rules. And will it go back in the other direction to some degree? That's entirely possible. The challenges of getting getting a HIPAA amendment or a general privacy law through the U.S. Congress are formidable. And go back to the origin of HIPAA, Congress didn't write the statute. They said, if we don't write a statute in 2 years, then we're going to empower HHS to come up with comprehensive regulations. And Congress did it for 2 years. And suddenly we had the HIPAA privacy rule. The security rule had already been written at that point. But I do believe you correctly described the situation. There's also the issue of rolling this kind of technology out for the benefit of consumers. Will it expand, kind of selling one by one? In other words, if you've got to enroll the consumers on an individual basis and get them to use the technology, versus finding some way to get, say, here's something that's just available to you now, which suggests to me that there might be some distribution channels that are more linked to covered entities. Like a big health system saying, we have a new tool, and if you want it, either it's available to you, or you can get it for some reasonable price. Similarly, a plan might have say it would be advantageous for us to upgrade our interaction with our members through a new kind of app. I think what they've envisioned is something that's untethered to providers and plans, and therefore will be market changing. But then you have the question of one, who says that it's safe to use, who sets the ground rules to increase consumer confidence, and also, how do you monetize this thing? Right. Last I heard, even computer programmers need to be paid. You can't just tell them to go, do all this work for free. What's the monetization strategy for this? If a health system or a plan says, we're going to develop it, or we're going to buy it, on the market, but use it with our members or patients, then presumably it's enhancing their business model. If I'm a freestanding app developer, well, how am I making money off of this thing? Is it because I'm harvesting the claims and doing data analytics service and selling that information? Is it the age-old dream of how you pay for health information, which is we'll sell the data to pharma, which, is kind of everybody's last default at the end of the business plan. If we can't do anything else, we can get money from, the big pharmaceutical industry players to pay for this thing. That's a lot harder now, the way the HIPAA rules have been changed since I.
A lot of them have an M&A strategy.
I'm sorry, I didn't catch that.
A lot of apps have an M&A strategy. They want to get bought by a big player and get their money that way.
Right. So, how many of these things is Optum willing to buy? Or some other big player. And then what is that?
All of them.
But then where do they sit in the infrastructure? Does that really make it a plan-oriented thing or a provider-oriented thing?
Good question.
I'm not saying it's impossible to do that. I'm not saying it's impossible to monetize these things, but I don't think the strategy necessarily is apparent right now. Are these, are these analytics plays, or this is a consumer? I mean, look, if Apple said we're going to build this thing into the iPhone and into the Apple Watch, that would be a whole nother, or, Google puts it into their phone operating system. But what makes it go from an economic point of view? I'm not sure that's been fully, who was it? Was it Google spent a lot of money on Google Health, and they had John Halamka on their board of advisors, and everybody, all these big systems were saying, we're going to support Google Health and dump all your data into Google Health, and it's going to be wonderful. And, I'm not sure anything at all remains of that initiative. The same with the Microsoft Health Vault, right? Just gone. They didn't figure out a way to monetize it. So now there are smarter people about these things from me. I freely admit that.
Yeah. There are a lot of services strategies too for apps where the app itself is free, but you pay for customer support, you pay for services, additional services. There are ways that these apps can get monetized without data selling. But that's a different issue for another day, and I don't know what it's going to end up being.
Yeah. Well, I guess the question there is, what are people willing to pay for?
Yep.
Right? Would you pay $100 a year for this service? And how many people would pay $100 a year? I used Noom for a while. I was surprised how much that cost by the end of, you know, a little over a year. So, you know.
Yeah,
Now-
it's definitely interesting.
So, you know, Denny, maybe you can bring in some venture capital or PE types or, you know, folks that are in the venture arm of some of the payers and talk about their point of view about these kinds of things. I think that to have a business.
I think that's a good idea. Let's talk about the business of health data apps. That's a great idea.
So, Denny,
Other
you know
questions from folks online?
I want to give other people a chance, but I have one more that I do want to ask if no one else has.
Oh, go for it.
All right. I know there were some changes to the Stark law at the end of 2020.
Yep.
Can you talk a little bit about those? I apologize for hitting you unawares if you are unawares about that. But
No, I am aware of it. I've got 2 big fat notebooks with all the
awesome
proposed rule stuff sitting on my bookshelf here at home. Basically, the Stark rules were changed, and also anti-kickback safe harbors were changed. That's why it's 2 big notebooks and not one. To make it possible to have financial incentives to physicians for value-based care programs without, you know, sending anybody to prison in the case of the anti-kickback statute, or providers generating enormous false claims liability under the Stark rules. So that included the ability to have certain kinds of incentive payments to individual physicians through service contracts around meeting goals of certain kind of risk-based programs and value-based programs to reduce cost and improve quality with safeguards for patient safety. It includes more kinds of incentive programs through risk sharing and risk things that meet the standards of being a risk sharing program under the rules. If I was going to speak to you intelligently about the details, I'd need to pull out the rules again and refresh myself on the way they exactly worked. My general reaction in reading them is that there are some things that are genuinely completely new, especially around payment of incentives through service contracts as opposed to risk-bearing arrangements. I think a lot of it is just elaboration on things that probably people have been doing for a while under existing safe harbors and Stark exceptions, but maybe with a little more clarity and a little more guidance. The government, and when I made my snarky remarks about this dragging on since 2008, generally speaking, the government is extraordinarily cautious about loosening up under either of these statutes because of the real concern that there will somehow be a secret purpose or an additional unspoken purpose to simply incentivize providers and especially physicians to direct referrals to a particular health system or a particular designated health service provider like a lab or an MRI center or whatever. So there's enormous conservatism and caution in the way these rules are drafted, which is probably warranted. And if you didn't have that, what would people like me do anyhow, in terms of dealing with these things? So that's the very high level. If I had to get it, if there was an interest in getting into the details, I'd probably want to look at it and put together at least a short presentation on it. But that's the overall, is more about how to do incentive programs under shared risk arrangements. And there's a lot of definition about what's a qualifying shared risk arrangement between a plan and a provider and physician groups to implement those things. So I'm probably not really answering your question very specifically, but that's in general what the theme of those rules are. And they are fairly complex, and like Stark itself is complex, and filled with commentary in the rulemaking. It has gone effective, but I haven't heard about, what do I want to say, transformative new kinds of structures that are being built with these rules. And, you know, there's still a certain amount of debate about whether some of the risk-bearing arrangements are really fruitful or not. I think the consensus, at least in Massachusetts, is that they are, but in other parts of the country, It's people are less, not everybody is sold on it, I think, as we are here sitting here in the People's Republic. So
Thank
Denny,
you.
Yeah, sure. Denny, you know my general feeling about ending meetings early.
Yes, we can end this meeting with 8 minutes to spare, David, and we want to thank you. We want to thank you, Bill, Dave. Any final comments from you as the co-chairs of the CIO Forum?
This has been a really interesting talk, and I appreciate Dave's insight into the legal aspects of this rule. Thank you. Thanks everyone for joining. I found it very interesting. Hope you did too.
Thank you very much. Oh,
I
sorry.
concur, David. You know, a couple hours of very valuable legal advice. Denny and David, are we able to share this deck with those of us that are on the
Yes.
Zoom? I see the thumbs up. Yay. Thank you, David.
Yes,
Yep.
all members of the CIO Forum, all individuals who have access to the CIO Forum, executive and partner members will see this on our website, both the recording of the webinar as well as the presentation that was used. So give us about 72 hours and we will have a clean and buffed up version of the video and David's presentation available for anyone on the who's eligible for it.
Thank you, MHDC, and thank you, David Szabo. We appreciate it.
You are quite welcome. Thanks so much. Always a pleasure to see and talk to everybody.
Thank you, David.
Thank you,
Take care,
David.
everyone.
Take care.